From the Leslie Dan Faculty of Pharmacy at the University of Toronto, this is the I'm Pharmacy podcast, and I'm Mina Tadros. A few years ago, a bus full of Americans crossed the border into Canada with Senator Bernie Sanders. They weren't coming for sightseeing, they came to buy insulin. At the time, the same exact vial that cost hundreds of dollars in the United States could be purchased here in Canada for a fraction of the price. The images and the media attention of that trip were striking. Patients clutching bags of insulin, grateful but also angry, wondering why they had to leave their own country to afford this life-saving medication. That moment for many crystallized something we all knew, but often avoid saying out loud. US drug pricing was broken. Most striking is the fact that it is one of the few issues in the United States that is currently largely nonpartisan. Left or right, most Americans agree the prices are too damn high. No matter where you fall on the political spectrum, if you or a loved one needs insulin or a cancer drug or the latest biologic, affordability was a major roadblock if you don't have the proper coverage. Now, why is the US so different from its neighbor to the north? Here in Canada, as in most countries, drug prices are not left entirely to the market. Federal and provincial systems negotiate, cap, and sometimes reject prices outright if they're deemed too high. In the US, however, drug pricing grew out of a fragmented system, with payers from the public sector, Medicare, Medicaid, private insurers, and then the emergence of pharmacy benefit managers making their own deals. When Medicare Part D was created in 2003, Congress even banned the government from directly negotiating drug prices. That decision alone set the stage for decades of escalating costs. Manufacturers learned to launch drugs at extremely high list prices. They used secretive rebates and discounts to secure coverage from the insurers and PBMs. Patients were left to pay out of pocket if they had to, and they often bore the brunt of that relationship and didn't get any benefit of these negotiated prices. And unlike in Canada, where government plays a central role in holding down costs, in the US, political gridlock and aggressive industry lobbying has made reform practically impossible. But in recent years, we've seen movement. The Inflation Reduction Act gave Medicare authority for the first time. The government started negotiating prices. This was a very historic change. And most recently, we've seen the new proposal for the most favored nation pricing, tying US prices to those in other countries. And it helps curb the power of pharmacy benefit managers whose practices are often opaque and controversial. And before everyone gets a gaffe given the political discourse that's ongoing, what's being negotiated or proposed in the US is literally what we have here in Canada with the PMBRB. Still, reform in the US is slow and messy because every step touches powerful interests and carries trade-off. Lower prices may improve access, but raise fears about reduced investment into new therapies. Negotiations can save billions for taxpayers, but might change what drugs are actually covered. And transparency reforms threaten to unravel hidden financial flows. The bottom line is this as we think through this. Unlike the bus of patients heading north for insulin, most Americans can't simply cross a border to escape the system. They live with it every day. And that's why on this episode of the I'm Pharmacy podcast, we had a chance to really dig into the complex issues, unpack how the US ended up with the most expensive drug pricing in the world. We explore this episode with Dr. Jerry Avorn, who is a pioneer in pharmaceutical policy and pharmacoepi, and an author of a new book, Rethinking Medication, Truth, Power, and the Drugs You Take. Let's jump into it.
I'm Jerry Avorn. I'm an internist and a professor of medicine at Harvard Med School. And about 25 years ago, I set up something we call DOPE, which stands for the Division of Pharmacoepidemiology and Pharmacoeconomics, which is a research group based at Harvard Medical School and the Brigham and Women's Hospital. And I also helped Aaron Kesselheim to co-found a program called PORTAL, which stands for Program on Regulation, Therapeutics, and Law, where we look at a lot of medication-related policy issues. So we're pretty good at acronyms, if not much else.
So maybe we could start off. This is actually your second book, from my understanding. And so why come back to this topic, and what drove you to want to write this book at this time?
Okay, good question. The last one was 20 years ago. It was called Powerful Medicines, the benefit, risks, and costs of prescription drugs. And it was published in 2004 by Knopf. And that was at that point kind of everything I could think of putting between covers about literally the benefits, risks, and costs of medications that I had been studying since I finished my residency in 1977. So it's a long-standing concern. And then about 2 years ago, I said, gee, it's been 20 years. A lot of stuff has happened since then. And I felt like it was time to put the rest of what I know under or between covers. And that led to the publication of Rethinking Medications.
So when did you start writing it versus like the timing of it and the release? As I was listening to it, I'm sure you didn't imagine what was currently happening in the US environment in this space, but it's serendipitous. I don't know what to call it, but it's pretty remarkable. So when did you start writing it? And then the context of what's happening right now in the US in the pharmaceutical policy space.
Right. It has been an unanticipated but amazing confluence of events. Well, since it's based on papers I've been writing with my colleagues for, a couple of decades, some of that work has been going on for many, many years, but I decided that it needed to be a book maybe about 3 years ago. And I just started dictating into my little computer everything I could think of about how do we know if a drug works? How do we know whether it is safe? How do we know if it is the right price? And we were wrapping it up, or I was wrapping it up, really in the tail end of 2024 and the very beginning of 2025. And the publisher over at Simon & Schuster were saying, you should just correct typos and spelling mistakes at this point. And I would say, no, this is really important because whatever is going on now in the U.S. derives from all the issues that I happen to have been writing about without having a clue that we would be in an era where people were, not just people, but the head of our Department of Health and Human Services, among others, would be making outlandish claims about what treatments don't work or do work, or about what's safe and not safe. And so all of the issues that I was building into the book were now kind of plastered across the headlines, at least in the U.S., and I assume in the rest of North America and around the world. So it became way more timely than I ever wanted it to be over the course of the last number of months. And luckily, the publisher did let me make those last-minute changes so I could refer to some events that are right now unfolding.
Yeah, what I really loved about your book is the historical aspects of how we got here. You really start back from all the major acts and laws and changes that have happened, all the way from why the FDA was even created to begin with till today. If you had to pick a moment or two that really catalyzed why we're at the situation we're at today with high drug costs, some questionable oversight in some places, what do you think the misstep was, if there could be one or two? I know it's hard to, the book argues that there's a series of them, but what do you think the biggest catalysts were?
Well, I think it might help to categorize them into the missteps about our knowing whether medications work, our missteps about knowing whether a particular drug is safe, and our missteps about getting the price right. I guess on the efficacy side, the one moment I would highlight about how we could have done a better job was when, with all the best intentions in the world, in 1992, the FDA passed a regulation that you could get accelerated approval for a drug even without showing that it worked. And at the time, it was the height of the AIDS epidemic. And the concern was that FDA was taking so long to do its randomized trials that it was, people were literally dying in 1992 because they needed treatment for AIDS, and even promising drugs were taking very, very long to get out. And so that was a good idea at the time, but it opened the door to what turned out to be a pretty abusable arrangement in which these so-called surrogate measures, while fine in 1992 for AIDS, have now become a source of massive abuse by the industry. So that was the issue around getting cost wrong. Getting safety wrong. The one moment that I think was pivotal, and which our research group over at Harvard got in the middle of, was Vioxx. And many of us had been concerned that it was likely to be causing excess rates of myocardial infarction or heart attack and stroke. And the manufacturer said, no, 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 that can't be. You're making this up. And then, of course, in 2004, it had to be pulled from the market because it caused excess heart attacks and stroke. And the good news, if there is any from that, is that it did launch a new era of really systematic pharmacoepidemiology that was given new life because the Senate, among others, hauled in the head of the FDA and said, why was this drug on the market for 5 years and no one knew this? And that paved the way for the creation of the Sentinel system. And I know there's programs in Canada and throughout Europe that are doing the same sort of work of looking at actual utilization data and outcomes to learn about problems before, in the case of Vioxx, 20 million people were exposed to it before we really had solid evidence of its problem. I guess the last one, since I squeezed 3 examples from your question, would be on the cost side when a decision was made by Medicare back in 2003 that made it illegal for the government to negotiate price about medications. And that kind of set the stage for what I feel were lots and lots of years of abuse in which manufacturers would charge whatever they damn please for a drug. And the Medicare program, one of the biggest purchases of drugs in the country, was powerless to push back. So I guess those are the 3 kind of elements that I would say were pivotal moments where we could have gotten it better than we did, but at least we can look back and learn something.
And do you think, like, I couldn't help but pause as you were telling the stories that part of what's happening right now, the distrust in the system, the questioning of if there's people even studying the safety of these drugs, and the question of where of the prices being fair, were all sort of allowed to occur, and now they festered, and now that's why we're getting these narratives that currently exist. So how do we rebuild trust in these? You know, the FDA is the crown jewel of all regulators, right? Like, if you think about it, you argue they're underfunded in some ways, and we could talk about the funding and how they get their money in a second. I have a question on that. But if they can't do it, like, how is a place like Health Canada or even the EMA, which is a little bit small, like, able to handle all of this?
Well, I got to say that here we are in late 2025. I am feeling way more comfortable about the way Health Canada and the EMA and the authorities in Japan and Australia are handling these issues than I am about how we are handling them in the U.S. I think we've gone, as you said, from kind of I hate the word gold standard has been so badly abused by the administration, but the example that the world looked to starting in the 1960s in the FDA to now a really kind of wrecked up organization along with the CDC and other parts of the federal health apparatus, that I feel more comfortable talking to my beloved colleagues in Canada about how do you folks handle looking at this drug's efficacy or its safety or its cost than I do relying on what has become of the FDA's approach to this. And that's a very sad thing to say. So about the science is really, as science tends to be, pretty universal around the world. I think, you get a bunch of smart pharmacoepidemiologists or pharmacologists or economists in a room, and mostly they can kind of agree on here's how one ought to do the science around these issues. But where things have fallen apart is that we don't really do the science at the moment in the U.S. very well. The people who do it are still there, but as we know from the current headlines, they are being overruled right and left, and so their voices have really been muffled.
Some of the current proposed changes, especially around pricing, this has been a big pain point. For a long time, it was a nonpartisan issue. Drug prices at their sticker price, their net price, was really high in the US. Like, in some cases, some analysis have shown that from between Canada and the US, the average drug price could be 2 to 3 times more for the exact same product if you walk into one place or another. It could be even higher, actually. So this new most favored nation proposed policy is basically what Canada does, right? We have like a basket of countries. So he's proposing, for the Canadian listeners, the PMBRB in many ways. And so it got me thinking, from your perspective, as you look around the world, what countries are doing it right, whether it's pricing or regulation? And are there lessons for the US?
Okay. And I would say this even if I were not talking to a Canadian, but I think Canada really does have, Canada, I think, does really have a very sane and effective approach to doing this. I also think that Western European countries, including Germany and France, also have a very good approach in that in all three, just my favorite countries to mention in this context, there is a systematic review of how good is this new drug? How is it better, if at all, compared to what we've already got? And what is a plausible mechanism for trying to assign a fair value so that, companies, if they've got good drugs, ought to be rewarded, ought to be able to make a handsome profit, ought to get paid enough to make up for all the false starts and dead ends that drug companies have to endure. And so I'm all for rewarding companies generously for good products, but I'm also utterly opposed to rewarding them generously for products that are no better than other stuff we've got that is way cheaper. So I do think Canada really does that very well. And the healthcare technology assessment groups, or HTAs, in particular in places like France and Germany, do it very well also. I would mention NICE in England, but with a footnote that although they really are among the granddaddies of looking at cost effectiveness of medications, and they do it very thoughtfully and very well, they sometimes, as is the rest of the British National Health Service, a little bit on the stingy side. And so all that great thinking and good evaluation sometimes comes to a bit of a compromised end when the whole healthcare system in the UK, as far as I can tell, is underfunded. And so that gets represented in drugs too. But NICE, deserves credit. The National Institute for Clinical Excellence, or Healthcare Excellence, or they changed the acronym since the old days. But NICE in England and those two Western European countries and Canada, I think, have got great mechanisms. And, I note that drug companies have not stop doing business in those countries because they feel that the prices on the drugs are unbearable. They do fine in those countries. Otherwise, they wouldn't be doing business there. But it's a much better way of having the healthcare dollar or pound or euro go much, much further because you're not wasting it on drugs that are horribly overpriced.
Not to defend the current administration, but I do feel like they know that drug prices is a nonpartisan issue, and the Senate hasn't been able to figure it out, right? I think for a variety of different reasons. And so they come up with these sort of half-baked policies, bring drugs in from Canada, a basket of countries, letters to the CEOs, whatever it may be. But they are trying to tackle a problem. Like how realistic do you think it would be for the Senate to come up with something? Like it's like the policy appetite seems to be lacking.
Yeah, it depends what you mean by realistic. Conceptually, as in Canada and our colleagues in other advanced countries know, it's doable. There's controversy about how do you value this and that, but it's within the boundaries of stuff that reasonable scientists can agree on the right way to do it that would at least bring into control some of these ridiculous prices that we are paying for drugs that don't work or have never really been rigorously tested with patient outcomes. So it's doable. But of course, the problem is the politics. And in the US, the pharmaceutical industry is one of the very biggest lobbying presences in Washington. And even a reasonable thing is not likely to ever make it through Congress. And while President Trump's been doing a lot of yammering about most favored nation status or reference pricing or looking to Canada, most people I know say that while he may get a charge out of his audience when he yells about that, it is extremely unlikely that anything like that will ever get through Congress because of the fact that lawmakers on both sides of the aisle, Democrats and Republicans, are so beholden to the pharmaceutical industry for funding and so subject to their massive lobbying presence that it just isn't going to get passed. And Trump can make all the speeches he wants. I don't think we're going to be seeing very much difference in the coming years.
So one thing that also struck me while I was reading your book was I'm struggling. Like I live in this space, and to keep up with all the information and feel like you're not being sold something, or to know the true value of a medication, if it's safer, if it's efficacious, is challenging. How how do patients or the public do this, which are some of the readers you're hoping to have for this book? How do they stay informed? And what do you recommend for them as they're trying to digest and navigate all this information?
Great question. And the publisher told me, and it turns out to have been a smart idea, to put a section in the book that's an appendix on how patients can get good information about their medications. And I recommend a bunch of sources that are reliable and not commercial fronts for a drug maker and are not sort of crazy, paranoid, MAGA type sources of disinformation. And so that's there without going through every single one of them. Clearly, it's a social good that I think any country needs to somehow support the existence of, just like we support things like roads and, public education. And we used to support clean air and water in the U.S. And the idea that there's something that you shouldn't have to buy for yourself. And so both for the patient audience and also for the doctor audience, there needs to be, and again, CEP in Toronto does this well. British Columbia has done very good things over the years in that regard as well. And of course, I don't want to insult any provinces, but there are great programs all around Canada and the US and Europe. Australia had in the past a nationwide academic detailing program for its GPs. So once we live through the next couple of years in the U.S. or Canada's there already, I think a lot of attention needs to be paid to the idea that just as there are some things that governments pay for everybody because it's a social good, this is one of those things with an arm directed at patients and an arm directed at prescribers. And ironically, and this is literally in the last few days here in the States, there's been a bizarre turn of events that could actually end up turning into something good. And that is, as you and your listeners will probably have heard, in the face of all of the disinformation and bad junk science that we've been hearing in the last number of weeks and months about vaccines, a number of states in the U.S. have banded together and said, we're going to put out our own recommendations about vaccines, when people should get them, what's safe, what's not safe, because clearly the HHS department, Health and Human Services, is not doing it. CDC has been castrated. And the downside, of course, of all that disinformation is that while nobody's going to go out and arrest you for getting a vaccine, if your insurance company isn't going to pay for it, because the fact that the people who make those recommendations in government have been fired and replaced with anti-vaxxer hacks by RFK Jr. So some states, starting in the Northwest, but now also here in Massachusetts and on the Eastern Seaboard and in the Midwest, are saying, let's come together and put together the best science without ideology, without politics, without paranoia. And they're doing that initially for vaccines. But the way in which this is a kind of roundabout, optimistic answer to your question is, wouldn't it be great if, especially given FDA's failings over the last couple of years of approving drugs that don't work, like Aduhelm for Alzheimer's, or all the muscular dystrophy drugs that don't work and can be dangerous. What if the states were to say, okay, we're going to take this upon ourselves and create a national consortium of public sector people and hire only or work with only people without any conflict of interest, make sure that everything that we say is based only on the best evidence, and then put it out there, hopefully in a non-obscure way, so that doctors and patients can access it. Wouldn't that be a great kind of silver lining to the ugly cloud of the FDA and the CDC dropping the ball on this in the current administration?
So if you'll allow me to selfishly pivot a little bit, I want to talk about academic detailing. It's something I've gotten to be involved in and study. And I think that's actually the first time I ever met you at ISPE. I came to one of your sessions on the topic as a student. And how did you come up with it? Like, can you tell us a little bit more about early days when you were thinking about it and the naming? Like, why didn't you just call them good guy pharma reps? And maybe tell us a little bit, and for our listeners, describing what academic detailing is. It's such an important piece of your story, I think. I'm sure there's lots of important parts, but I think like it's the part when I was knowing I was going to get a chance I wanted to ask about.
I am so glad you did. And as you might expect, I would be delighted to talk about that. And, the origin of all this is, in gory detail in Rethinking Medications. But as far as the sort of abstract of it, it started when I was a medical student. I've been at Harvard Medical School since 1969. So this goes back to the early 70s. And I'm sitting there in these big amphitheaters, which is where we used to do all the teaching. And we were learning all this great pharmacology and great ways of thinking about evaluating meds. And then they would occasionally let us out into the real world and we would see doctors in practice. And the prescribing kind of on Main Street, so to speak, was dramatically different from all the really, really careful science that we were being taught in the classroom. And I began to wonder why that is. And then I came to understand that the pharmaceutical industry was really very adept at putting its perspective in front of the doctor about what they wanted us as prescribers to know. And I saw a ton of this when I went into primary care after finishing my residency, and they were often, lines of sales reps or detail men, usually men in those days, trying to get to see the doctor. And they were so damn good at presenting the field of how do you manage diabetes or hypertension or whatever in a way that led right up to the conclusion, oh, so you should use our company's product because it's the very best and most modern and most effective. And while they didn't make stuff up because they were limited by what FDA said they could say, for the most part, there's some interesting counterexamples in the book. But in general, what was different was that they were adept at marketing information. And they had read all the wonky literature about adult learning theory and how do you change behavior and all that stuff that, my peers in academic medicine would, go into a darkened auditorium and give grand rounds and show a bunch of slides while people sort of dozed off over their donuts. And we're not coming at it from the perspective of what the prescribing doctor really needed to hear. And, we just did a crappy job of it in academia, and the drug companies were running circles around us in order to sell their product. And some of the very simple question that I began to wonder about right when I finished my medicine residency was, shouldn't it be possible for those of us in academia to get good at the exact same kind of interactive, behavior change-oriented conversations that the drug company sales reps were so good at? And as your listeners will know, they are known as detailers. And so I said, we should have something that would be like academic detailing, where it's a chance for people from academia with no commercial axe to grind, review the literature, but present it to doctors in an accessible, compelling way, interacting with them all the while, because a good either teacher or sales rep will do a lot of question asking and not just kind of say, sit still while I give you this lecture, but really say, so tell me, Dr. Avorn, how do you manage diabetes? And, oh, you're still using metformin. Nobody uses that anymore. And draw out the prescriber. And in doing so, learn where that particular doctor, or these days nurse, or occasionally pharmacist, is coming from in making their prescribing decision, and then tailor the intervention in a way that will get at what that particular learner needs to hear, not give them a canned speech about, here's the 8 points I'm supposed to cover before I let you say a word. So that's where the concept of academic detailing came from. And we've now, as many of your listeners will know, we set up a not-for-profit called Alosa Health, ALOSA, which I named after the kind of fish that swim upstream, like herring, because I felt like we were always swimming upstream. And we just put out our stuff there for anyone to use on a non-commercial basis. We're working on a module on diabetes now. And we send people who are very well-trained pharmacists or nurses, usually. We have a couple of MDs also, to visit with doctors and interact with them just like a sales rep would. But the only goal is to communicate the very best non-commercial information in an interactive way that'll improve prescribing.
Yeah, and it works. I could tell you from the work we've done in Canada, where we have some really great programs that do it. We've been able to improve opioid prescribing, antibiotic prescribing, and most recently we actually did a diabetes one as well, that this group CEP was able to get people to use biosimilars sooner, switch to guideline-driven practices. And so it's a pretty remarkable thing And it's pretty amazing. Like it's such you think about it, like somewhat simple idea, but the impact of it is really massive.
Right. And I'm aware of the work of CEP in Toronto, and they just do fantastic work. And as you said, that those original studies, which I tested in randomized trials around the country, because I figured it's a neat idea, but I got to show that it works in an RCT. Otherwise, no one, including me, is going to believe it. And then people have picked up the CEP in Toronto, and there's wonderful groups all throughout, not just North America, but also in the rest of the industrialized world, that are saying we cannot leave the discourse about what to prescribe only to the companies making the product. And we got to do a better job than the boring continuing education that we put out from academia. So yeah, it's been adopted, and that's been one of the joys of my life, that I was able to kind of come up with an intervention that's not a molecule, but it's kind of a way of communicating that can really make a difference.
Dr. Avorn's book was released at a time where we're seeing lots of movement in the pharmaceutical policy space. And to me, what does this all boil down to? I think it comes down to three main points. The first, that what we've seen is decades of failure on the policy level to be able to act, largely due to the fact that many people were conflicted. Lobbying groups did a great job, and what we saw was indecision, which led to a rising effect on patients. The second is that we saw fear that lowering these drug prices would not bring amazing new discoveries. And I think there could be a balance that's reached around the world of how we can support innovative products that improve lives, but at the same time ensure access. And third, and probably the most important, is how do we make sure that patients get the treatments they need and that price is not in the way? Because what's the point of inventing, developing, and getting a drug approved if the patients can't get them? It's complicated, it's messy, but it seems like things are moving in the direction of trying to lower those drug prices. This episode of the I'm Pharmacy podcast was produced by Steve Southon, Kate Richards, and me, Mina Tadros. Musical accompaniment was from Steve Southon and Diego Martinez. This episode was edited by Steve Southon. Special thanks to Dr. Jerry Avorn. Just a quick reminder, make sure to subscribe to this podcast wherever you listen to podcasts. And if you don't mind, leave us a 5-star review. We'll be dropping new episodes every single month, so make sure to subscribe wherever you listen to your podcasts. Stay safe and keep asking questions. Catch you at the next episode.